Peace. Welcome to your YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. So we completed chapter 20 last reading. So that means we pick up, wow. Welcome, YouTube, to the peace, to the midnight edition. This is episode 55. All right. Section 6, Airway Pressure Therapy. See, we're there. Welcome, YouTube. I was going to make sure I got it in. Super full moon has really been powerful and brought in a lot. So I wanted to make sure that give you this your place of peace, grounding, love energy. Reading books here on YouTube. Here we go. Chapter 21, Defining Airway Pressure Therapy. Page 321. Normal gas movement in and out of the pulmonary system occurs in response to pressure gradients that exist between the alveoli and the upper airway. Thus, it is reasonable, convenient, and traditional to use airway pressures as a reference point when discussing support of the pulmonary system. Whenever airway pressures are discussed, the reference or baseline pressure is always atmospheric or ambient pressure, since it is this pressure to which the upper airway is normally exposed. For ease of reference, it is traditional to refer to the atmospheric pressure as zero. It should be realized that this does not imply an absence of pressure as exists in a vacuum, but rather reflects and refers to atmospheric pressure as a baseline. References to negative pressures are always in relation to this defined baseline. Thus, a negative pressure of 10 is in reality a pressure of 10 units below atmospheric. It is traditional to refer to airway pressures in centimeters of water, centimeters H2O, rather than millimeters of mercury, millimeters Hg. Thus, throughout our discussions, it is assumed that we are referring to airway pressures in terms of centimeters of water and cardiovascular pressures in terms of millimeters of mercury. Airway pressures are assumed to be measured at the level of the trachea unless otherwise specified. Pulmonary pressure gradients. Since normal mechanisms of breathing are dependent upon pressure gradients, it is imperative to understand the nomenclature applied to pressure gradients within the pulmonary system. Figure 21.1. The pressure difference between the airway opening, mouth, endotracheal tube or tracheostomy tube, and the alveolus is referred to as trans-airway pressure or driving pressure. This is the pressure gradient that will directly result in movement of gas molecules into or out of the pulmonary system. Transpulmonary pressure refers to the pressure difference between the airway opening and the intrathoracic intrapleural pressure. Alveolar distending pressure. Alveolar distending pressure refers to the pressure difference between the alveolus and the pleural space. At FRC and expiratory lung volume, the alveolar volume is maintained because the alveolar elastic recoil forces are opposed by an equal alveolar distending force. Since alveolar and ambient pressures are equal at FRC, the alveolar to intrapleural pressure gradient alveolar distending pressure is equal to the airway to intrapleural pressure gradient transpulmonary pressure. Therefore, at FRC, the alveolar distending pressure and transpulmonary pressure are equal. Very key. Thank you so much for being here. Here we go. Figure 21.1. Nomenclature of pressure gradients within the pulmonary system. Left, transairway pressure, pressure gradient between airway opening and alveolus. Center, transpulmonary pressure, pressure gradient between airway opening and pleural space. Right, alveolar distending pressure, pressure gradient between alveolus and adjacent pleural space. So you'll see the transairway pressure in the first one, transpulmonary pressure, and then the alveolar distending pressure. As you'll see, there we go, 21.1 table. Thank you so much for reading with us. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So this is the second edition, 1979. Airway pressure cycle, figure 21.2. Inspiratory driving pressure is generated by the muscles of ventilation, primarily the diaphragm. Yes. Rapidly increasing the chest volume, thereby creating a decrease in intrapleural and alveolar pressures. Boyle's law. This drop in alveolar pressure creates a trans-airway pressure gradient, which results in gas flow from airway opening to alveolus. For any given trans-airway pressure gradient, the primary factor determining the flow of gas to the alveolus is the airway resistance. That's right. Inspiration ends. Gotta get it going, right? Inspiration ends when flow ceases. Thus, at the end of inspiration, the ambient airway, the alveolar pressures are equal, and therefore transairway pressure equals 0. The expiratory driving pressure is primarily the result of elastic recoil of the lung tending to return the lung volume to its resting state, or FRC. These elastic forces create an increased pressure within the alveoli, producing a transairway pressure in the reverse direction. This results in flow out of the lung. The rate of expiratory flow will be primarily affected by the airway resistance factors, although lung compliance and chest wall compliance also plays a role. Expiration is when the next inspiration begins. Note that the airway pressure normally returns to ambient at atmospheric prior to the end of expiration. That portion of time at the end expiration, when airway pressures are ambient, reflects a period of absent or near absent flow. This is often referred to as the expiratory pause. Woo! That's so good. Hi, his heart love. All right, here we go. Figure 21 2, right? Says A, normal airway pressure cycle. Inspiratory time begins when airway pressures fall below ambient. See text. Flow into lungs results and continues until airway pressure returns to ambient. Expiratory time begins when airway pressures rise above ambient. See the text. Follow out of lungs or flow out of the lungs ceases prior to the next inspiration, providing an expiratory pause, i.e., the latter portion of the expiratory time in which airway pressure is ambient and therefore no flow is occurring. B, 5 consecutive breathing cycles. Note consistency of expiratory pause. All right, there we go. That's how we were analyzing this. 5 breaths. See that? 5 consecutive breathing cycles. So those are taking notes, and 4 in the replays in the playlist. We want to take note of that. Here we go. This is the inspiratory time and inspiratory flow at the top. Expiratory time, expiratory flow, and expiratory pause. The pause is always after the expire. All right, expiration. Here we go. A and B. As you see, it's shorter, the time longer. All right. Thank you so much. 21 2. This table from Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you for being here. This peaceful part of YouTube where we read books and learn from masters. So, wow. You were born in September? No, right before September. Yes. Thank you so much for being here. Thank you, Snake, QT, OT. All right. The bottom of page 323. Yeah, this the month before, right before. Because today I'm what? 16,846. Yeah, yeah. We're here now. All right. Defining airway pressure therapy. Acute respiratory intensive care is concerned with manipulation of airway pressures to provide improved ventilatory mechanics and physiologic gas change. Such airway pressure therapy includes inspiratory maneuvers, primarily ventilator care, and expiratory maneuvers, primarily PEEP therapy. The discipline of applying airway pressure therapy to the critically ill patient is confusing and frustrating to most clinicians. A great deal of this confusion is attributable to the complex physiology, physics, and technology that must be understood. However, much confusion exists because of the alphabet soup that has developed pertaining to airway pressure therapy nomenclature. Terminology in respiratory care is so confusing and contradictory that it is often impossible to separate differing ideas from differing nomenclature. It would be naive to and presumptuous for us to purport that Our particular preferences in terminology should or would be accepted by everyone. However, to teach clinical application of airway pressure therapy, we must arbitrate terminology. The following is presented solely for the purpose of clarifying how we define various terms and how these terms are consistently used throughout the text. We believe our terminology is consistent with the present mainstream of respiratory care and find no major differences between our terminology and that adopted by such organizations as the American Thoracic Society and the American Association for Respiratory Therapy. Here we go. The nomenclature and identifications. Middle of page 324. Thank you for being here on this super full moon energy, reading books, loving on the people, you know, leveling up. IPPB, intermittent positive pressure breathing. Inspiration by positive airway pressure. Expiration is passive, and airway pressure returns to ambient prior to next inspiration. IPPV, intermittent positive pressure ventilation. IPPB applied in a repetitive manner for the purpose of mechanically supporting ventilation. IMV, intermittent mandatory ventilation. Spontaneous ventilation intermittently augmented by positive pressure ventilation at mandatory intervals. IDV, intermittent demand ventilation. Spontaneous ventilation intermittently augmented by positive pressure ventilation on patient demand, i.e., in synchrony with the spontaneous pattern, also referred to as SIMV, synchronized IMV, and IAV, intermittent assisted ventilation. PEEP, positive and expiratory pressure. An expiratory airway pressure maneuver in which the airway pressure is maintained above atmospheric at the end of expiration. Page 325 at the top. Chapter 21. Look at this. CPPV, IPPV, and PEEP. The combination of mechanical support of ventilation and PEEP may also be referred to as the ventilator with PEEP or IMV with PEEP. And, ooh, yes, we made it here. Look at us. CPAP. The CPAP. CPAP. CPAP, continuous positive airway pressure. Ding. Continuous positive airway pressure, spontaneous ventilation, and PEEP with the most widely used technique for applying PEEP to the spontaneously breathing patient. The apparatus must allow for inspiratory air pressures to be maintained above atmospheric, i.e., the entire breathing cycle must have positive airway pressures. Yes, yes, the great CPAP and EPAP, EPAP. Expiratory positive airway pressure, a technique for applying PEEP to the spontaneously breathing patient in which inspiratory airway pressures are required to fall below atmospheric in order for inspiratory gas flow to occur. The following four chapters discuss the physiologic and clinical principles of airway pressure support and their complications. For ease of reference and discussion, three broad interrelated areas are discussed separately. 1. Inspiratory airway pressure support to augment ventilation, ventilator care. 2. Positive and expiratory pressure, P. And 3. Combinations and complications of these airway pressure maneuvers. La 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 la. And we completed chapter 21. Yes! We did it! Now, when we go into chapter 22, oh my goodness, we did it. We did it. It's one of the longer chapters of this magnificent book. So, that's the principles of ventilator care. Oh my God. Amazing. We did it again, guys. We did it again. Shaking it up on YouTube. Reading medical, super high level books. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. Did it again. Thank you so much. Thank you. So grateful and thankful for all I have now and all that is coming to me. Thank you. You did it again. Floating on them, right? Thank you so much for reading books with us. Love to all the book lovers community. Love to all my mods, friends, and family. Yes, Lucy, it's me again. That's right. Shine in the light. That's what light workers we do. You know, heal the people. Tomorrow's Wednesday. Well, today is Wednesday, right? So we have the grocery giveaway. And today is the 300 weeks consecutively giving out groceries to the community here in South LA Cafe, live from the light. That's what we do. Thank you so much. We shake it up on YouTube, reading books, right? Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Love to all our friends and family. Love to all the light workers. It's a new age. It's a new time. We did it. And we're doing it. You're doing it. Every day you decide, right? How am I going to help the world? What am I going to do next? That's why we meditate, right? We're going to, yeah, the light green cloud tonight for rest, divine rising. When you get this message, know that I love you. We're at the highest level, so there is no debate, right? Let's have a glass of love water, right? For the people, to the people. I love you so much, man. It's Wednesday. We're going to the grocery giveaway. Help thousands of people. Cheers to South LA Cafe, Joe and Celia Ward Wallace. Thank you so much to all the staff, all the people that helped make this happen. We honor you. Thank you. I love you. I love you. I love you. I love you. Thank you for reading with me. Thank you for breathing with me. Honor. I love you. I love you. Because I love me. That's what we do as Lightwork. Uplift the people. Remember, when you take your walk, look up. See what you see, what resonates with you, right? Who in the world can help the world like you? Only you. It's all up to you. Thank you for being here. Highest heart love. I'll see you soon. Peace, peace.